Yakubu, manage. It's going to do you like you want to die, but you will not die. So, doctor, please help us. What do you have to say?
Many people who have social phobia, they tend to abuse substances to mask their phobia. For example, I'm going to perform before the class. That's when I started taking alcohol. So before I now know it, I become dependent on alcohol. I smoke a little Igbo to be able to make my performance.
Someone said I hate cockroaches. This
When you talk about threat of suicide, females will be dominating, so they always talk about dying, but they won't kill themselves. But men may not talk about death, but they may eventually commit the suicide. This is because they keep it in their mind, nurture it, and then carry out the action.
Good evening, everyone. Welcome to another impactful session with your mental health sentinel, Ogenewari Nabena. Before we dive into today's topic, I want to introduce our special guest, who is certainly not new to our community. Joining us tonight is the brilliant Dr. Justice Uchenna Onu. He's an associate professor of psychiatry and is a renowned mental health consultant. And his exceptional colleague that will be joining us later, Dr. Temitope Olatayo. It's an absolute delight to have you all here. Okay, if you missed our live session, the last one we had titled Beyond Village People, you missed a wholesome and eye-opening conversation. As soon as we finish this call tonight, I will advise that you head on to our YouTube channel at the Mental Health Sentinel to catch up. Today's session is special because today is Father's Day. Happy Father's Day to all the men in our community and all over the world. We celebrate you today and we appreciate you for all you do. It's not easy to be a man. We're also celebrating the Awareness Month for Men because June is globally recognized as Men's Mental Health Awareness Month. And this makes tonight's conversation very timely. Let's be honest to ourselves. Looking around us today, our economy, unending bills, daily hustle, unemployment, insecurity, the list is endless. Everywhere you look, pressure tiwa, pressure there and it choke. The society is not smiling. The men are not smiling. As much as they keep getting the pressure of be a man, you have to be strong, men don't cry. We know that they are not having it easy. And I know some of my sisters listening here will be like, but why? What about us? Our struggles as women, it's also heavy. My sister, I hear you and your point is valid, but tonight we are not competing, no competition about whose load is heavier, who is having it bad and not. As women, we have fathers, we have brothers, uncles, husbands, and sons. We also have male friends and colleagues. How do we see them? They might be going through some issues, and we all know men do not really open up to their challenges and how they are struggling. But that's why we're having this session, so we get to understand the men better. We also get to be able to be that safe space as well. So today we have Dr. Onu is going to be helping us break down the reality of mental health for the Nigerian men, the silent mental health crisis, and also tools to help us save lives. Before we hear from Dr. Onu, I would like to ask us a question. I want you to drop your answer on the chat. As a man, when you're going through life struggles, when you're getting really overwhelmed, where do you go to? And as women that are on this call right now, where do you think men go to when they are having life challenges, when they are struggling? All right, Dr. Onu, we thank you. We appreciate that you are here. We're delighted and we're ready to learn today. So I will hand over the baton to you. Over to you, Dr. Anu.
Thank you very much, ONA. It's raining heavily where I am. I hope I can be heard.
Yes, we can hear you clearly.
Dr. Temi, you can say hi to the house before the conversation starts. Yeah.
Okay, good evening, everyone. Happy to be back here. I'm looking forward to today's conversation. Thank you.
All right.
You're
So thank
welcome.
you, Temi. Yeah. Last time we started by saying that health is a composite of the physical, the emotional or mental, and then the social well-being. Now, these three have to interact together to give us our wholeness, and none is more important than the other. So, just as we seek to take care of our physical health, we must also have to endeavor to do things that can promote our mental well being as well as our social well being. For today's conversation, well, fundamentally, there are some subtle differences between men and women with regards to our emotional development. For example, we know that with regards to the brain development, that females tend to develop the capacities to speak and verbalize a little more. So when it comes to verbalization or things that involves communication, females tend to do better in that regard. Why males tend to do more with activities that require special kind of arrangement, for example, reading of map, orientation in space, so the men's brain tend to be a little more adapted to such activities, so a man can read the map better than a female on average. These subtle differences lay the background for the future development. So it obviously means that females are more likely to have friends and confidants, while men have just a little cycle of friends, one or two. This limits their social capital, it limits their social support system, unlike females that may have, several of them really that cushion the effect of their stress comparatively. So you can see that the foundation of the brain also lays some specific differences. And then when it comes to societal role, we find out that male child is raised with the understanding that men are not meant to cry, they are meant to absorb things. In fact, it becomes unmanly, if that is a good grammar, to cry. So, in other words, people tend to crying can be a way of ventilating your emotions. So bottling up things limits your capacity to ventilate. So men are more likely to seek for options other than ventilating. So they may more likely go into drink or smoke to forget their sorrows. While females are more likely to talk to another female, another person, of choice, to ventilate their fears. So these small differences in the way we cope, may make men to be more vulnerable to developing specific, mental health conditions. For example, it is also common that females may threaten to die in terms of suicide, but they may not commit the suicide. But men will not threaten, but they will go on to commit it. So when you talk about threat of suicide, females will be dominating. So they will always talk about dying, but they won't kill themselves. But men may not talk about death, but they may eventually commit the suicide. So threat threat of suicide commoner in females, actual suicide commoner in males. This is because they tend to bottle things, they don't get to share things, so they keep it in their mind, nurture it, and then go on to carry out the action. So, based on these subtle differences in development and societal roles, for example, there is what we call providers burnout. Men are supposed to provide for the family. Though there are some changes in the contemporary world, but fundamentally, it is expected that a man should provide. And this becomes some level of a threat to their mental health because of the burden that the society unwittingly placed on them. So these are the peculiarities of men, and the way they react to this stress can be diverse. And maybe that will be the focus of our conversation as we move on. We also will delve into depression, anxiety, and then substance use problems as the question comes up. So thank you very much for having us. We'll be here to provide answers to your questions. Thank you.
Thank you very much, Dr. Onu. I really love how you kickstarted this process. Welcome to all those just joining us. All right, you mentioned that male tend to, their brain development makes them less verbal about how they feel, and cultural expectation, financial burden. The man sits with this conditioning right from birth, like you said, childhood, where they cannot cry. Can you just help us explain how this affects the mind over time?
Well, all of us are born with some expectations. And naturally, when you deviate from the expectation, generally, I'm talking about generally, we all have expectations. There are expectations that our parents have about us. So when we fall short of it, there is some level of disappointment around those who have those expectations on us. And then invariably, those of us who fail to meet up the expectation also feel somehow about ourselves. So when the society have given men the burden of providing, and if perchance this individual fails to provide, two ways. First, the burden of providing can be enormous, especially when the means is not completely there. Two, failed expectations, because other people who think we should provide also have some expectations from men. So when people fail to live up to this expectation, there is perceived failure on the man himself, and then those he serves, the family, whether nuclear or extended family. This puts some subtle pressure on this individual, and this is the real definition of stress, because stress is obviously that requires some level of adaptation. So when there is failure on your part to provide, there is necessary adaptation for you, which is either that your spouse provides a little more, and then you may begin to have some inherent feeling. And this is really about self identity. Who am I? This existential question, can trigger a whole lot of reaction in people. Now, this is not universal. This is also based on how an individual perceives self. The complementarity of the female folks is very important in this regard. A female can diminish how the husband responds to his failures, why another one can make the failure seem so glaring to the world. So this is important because no one scenario is the same. So a man may obviously be having issues with provision, but the wife mitigates it. Another man may have issue with provision. The wife makes it get worse, or the spouse or whoever is around the individual, the partner. So the event itself, inability to provide, is an issue, but it may not have been issue if people around understand. So a couple of issues, the lack of provision itself is one. The reactions of people around the person is another. So what makes it stressful or less stressful is the perception of the individual, the man involved, and then the actions or inactions of people around the person. So, in other words, in mental health, an event is important, but the perception of the event and the reactions of people around makes the event either stressful or less stressful. So, it is when it becomes a distress that it can trigger some series of reaction in the individual. But if it is not a distress, the individual may as well cope. Thank you.
Okay, doctor, if I should digest it, is the way we respond to a man's experience or whatever he's going through is also a key factor to how it affects his mental health. Okay, in Africa, Nigeria, we have this communal kind of living where we also expect that the man is the head, the provider, and everything. So basically the responsibilities of men has been reduced to just financial provision for both the immediate family and extended family. But our men are made of more. I know money is important. Don't get me wrong, but seeing a man as just being money, seeing a man for just his wallet is also one of the major problems we're facing. A man should also be a protector. A man should also be there, available to even play with his children. In developed countries, we've seen stay-at-home husbands, and don't get me wrong as well, Africans will say, this one no know himself, but I've also seen families that cope well with that. The woman is earning more. They probably need like maybe 5 years to help the children grow to a particular age before the man joins her back at work. So the way it was the financial benefit to the home, let the woman go out and get more money to help the family. Why the man sits at home it doesn't reduce his manhood. He's still a man. So let's take it like we need to have that mind shift. In Nigeria, we have about 77% of men dying of suicide compared to the women. What are the likely reasons for that? And how do we sense that these men might be going through depression? Thank you very much, Doctor.
All right. So maybe, Dr. Temi, you may have to take on the common features of depression generally, and then maybe I'll just take on some subtle differences. So, Dr. Temi, go on, please.
All right. I'll start by describing depression as a mood disorder. The disorder part of it is because the symptoms have been present for more than 2 weeks and because it now begins to affect the functioning of the individual. I'm saying this because the symptoms of depression as standalone may not be indicative of a disorder. For example, one of the core symptoms is low mood, which we may also interpret as sadness. As human beings, sadness is on the spectrum of a normal emotional response to things that happen around us. However, when somebody describes having low mood most of the time and most of the days in a week, and this has lasted for up to 2 weeks, you may need to sit up and take notice. There is also low energy. They are not ill, it's not a physical illness, but they begin to notice that they do not have as much energy for their day to day activities. There's also loss of interest in previously pleasurable things. So for people that have hobbies, for people that have activities that they do, just seem not to be so interested. Things like football for the average Nigerian man that brings so much elation, they seem to no longer be interested. There might also be things like disruption in sleep, can be either way. The person can begin to sleep more than usual or begin to sleep less than usual. For sleeping less than usual, they may begin to notice waking up to 2 hours earlier than they would normally wake up. And appetite could also be affected. The person could experience reduced appetite or increase in their appetite. Libido could be affected. There might be no interest in sexual activity. They may begin to have feelings of reduction in self worth. They begin to feel hopeless and feel helpless. Some people might begin to experience guilt for things that have happened in the past beyond what is normal. When all these things come together and then you can trace it that it's been happening consistently for more than 2 weeks, then the person can be considered for a diagnosis of depression. Thank you.
Thank you very much, Temi. So your voice was waning and waxing. So but basically Temi have said that there are two fundamental things there. So there must be either a presence of sustained low mood that have persisted for at least 2 weeks, or loss of interest in activities that used to be pleasurable. It's not just a transient change in mood. It has to be sustained up to 2 weeks. So this is to reflect the fact that one could be sad because he lost somebody, and then few good things happen, you're okay the next day. So that's transient sadness. But depression is either a persistent one that have lasted up to 2 weeks or more, or loss of interest in activities, or both of them. So you may have changes in appetite, as Temi mentioned. Either it's you're overeating, and these are some subtle differences between male and female. Females may actually tend to overeat, while men may have loss of appetite, but they may also have loss of appetite. I mean, females. Now, changes in sleep, they may oversleep or don't sleep as much as they used to sleep, especially waking up at least 2 to 3 hours, as Temi mentioned. So there may be poor concentration, which may actually come like memory loss. When a young person talks about losing memory, I tend to consider a mood problem because it's due to poor concentration. So they don't necessarily get to register the information. So they think they are forgetting it without knowing that they never registered it in the first place. So feelings of guilt, hopelessness, helplessness, thoughts of not, thoughts of death, and sometimes even suicidal attempts and all that. Now, these are general features, but for men specifically, there are some subtle differences. You know, men are less likely to present with the full sadness, unlike females. Male may become a little more angry, irritable, like little thing provokes them beyond. So things that are not supposed to be issues now suddenly becomes so much of issues around them. So they get easily angry, over little or no provocation, you know, and they tend to act out a little more, like they drink a little more or soak themselves to work. So they may decide to actually
Mm.
overwork or just tend to stay away from people, drink a little more. So these are just basic little differences between male and female with regards to how they present. But generally, the features of depression are what Dr. Temi has mentioned. These are just slight differences when you see a man who gets unduly irritable, and this is a departure from his norm. There may just be some evidence that this person may be getting depressed. Yes. So thank you. So, but these features must lead to some level of disability. For example, the person is unable to function appropriately about himself. Your hygiene, you used to make up for females. A man used to care about his shoe. He knows no longer interested. His family function is reduced because he is not able to do the things he used to do for the family, or everybody now dreads him, which is not what he used to be before. And then his social network is either shrunken. This individual is unable to get out as he used to, do before, or starts making unnecessary mistakes at work. For adolescents, their academic destiny may drop during this period. So the presence of these symptoms that have lasted up to 2 weeks and is causing some significant distress may be an indication that this individual may have a major depressive disorder. Thank you.
All right, thank you, Dr. Ono. From what I've picked here, because in Nigeria now, you just hear the word loosely, I'm depressed, I'm depressed. Not everyone is actually depressed. Sometimes you're just sad. And like Dr. Ono pointed out, and also Dr. Temitope, it needs to be for a period of 2 weeks and beyond. So we get that now. All right, doctor. So what's the difference between depression and anxiety? And how can we differentiate between the normal financial stress and to say this is anxiety or clinical anxiety? Thank you very much.
All right. So depression and anxiety are problems of emotion, no doubt. And in, most of the times, they actually coexist in one person. Typically, when people experience events of loss, they may react with depressive mood. But when people experience events of threat, they may react with anxious mood. But some events of loss may also present threat. For example, you lose your limb, your
Oh,
livelihood may be threatened. You
mm,
lose your father, your school may be threatened. So you can see that these two emotions will almost always coexist. So when
yeah.
people have major depression, they will also have some anxiety symptoms. Now,
Mm,
but they are conceptually different, but these emotions can be mixed. So for anxiety, the commonest presentation is in two ways. first is what we call the psychological component, and then the second is the physical component. And it is important to know that the physical component actually will make people not to see the appropriate physicians, because the physical component will mimic what we already know. For example, the physical component is actually what we could say is autonomic hyperarousal, something that happens when you want to escape from a threat. So you remember your heart begins to beat a little faster, so that's what we call palpitations. You may even get to know that your heart is skipping, like you have increased the awareness of your heartbeat. So if you have sudden onset of your heart beating unduly fast, no danger, you didn't run, just suddenly you have this onset of your heart beating faster, you even know that there is a skip beat in your heart. Now, this is a common feature. We call it the cardiovascular feature of anxiety. But it also covers all systems. For example, the respiratory system. People may have what we call chest tightness. They are not breathing well. Many people actually end up in the hospital for emergency, like they have asthmatic attack. But once they get to the hospital, as the doctor is talking to them, everything gets okay. But they don't know that this is basically an anxiety attack. So it could also be in the abdominal system or the GIT, that's the gastrointestinal system, where they may have difficulty swallowing. They may feel there is a lump on their throat. This looks like physical illness. It's just that the doctors keep searching. They won't find much explanation to your symptoms. The cardiologists will do ECG, they do echo, they won't find anything to explain. And many of them may tell you to see a psychiatrist. You say, oh, I'm not mad or something, without knowing that really mental health is beyond the psychosis that people see. So virtually all systems may be affected. The tension, there is this persistent headache, among people with anxiety. They know that they have this headache. They know that this headache is not like that of malaria. So Africans describe it as heaviness of the head, like they are carrying loads in their head. This is as a result of muscle tension from the anxiety. So these are the physical symptoms, including disturbances in sleep. Now, what gives it away is the psychological symptoms. Now, these ones, the person may not talk to doctor about it. They'll just talk about the physical, because our people believe everything is in the body. But there is this fearful anticipation that something bad is going to happen to them. They have this premonition that something bad. So if you ask them, they say, Doctor, we do think that something bad is going to happen. In fact, they also have a catastrophic way of thinking. So that those things happening to their body, they give it a label. For example, if their heart beats fast, they'll think they're going to have heart attack, or they interpret it they have cancer somewhere or something like that. So they give it some level of interpretation that is beyond the threat. And that drives the threat, and that drives the anxiety, because nobody thinks that they are having stroke and they will stay somewhere. So a few things. When you start having non-specific symptoms in your body, you have cognitive symptoms like fearing that something bad is going to happen. You have concentration difficulties. You easily get startled. A knock on your door, you want to jump, like you're on edge or something. And then you have this persistent headache that is recalcitrant. You have treated malaria and typhoid 100 years and nothing has changed. You may just be having features of anxiety. And most importantly, there is excessive health seeking behavior. They will move from one laboratory to the other, from one doctor to the other. In fact, sometimes they will refer them back to one doctor. They say they have been there before, because they are looking for a physical reason for their symptoms without knowing that their symptoms are actually mental, and appropriate care have to be taken. Just to end, anxiety is just the general name, but anxiety disorders are not just one. We have about five of them. We have what we call the generalized anxiety disorder. You have the phobic anxiety disorder. You have the panic disorder. You have separation anxiety disorder and selective mutism. These are the five domains of anxiety disorder. So all anxiety disorders will give you the features I've described. But what differentiates one from the other is the nature of what provokes it. For example, in generalized anxiety disorder, the worry is always about everyday life, finances, relationships, food to eat, security, just a worry about everyday life, and it tends to be always there in the individual. They are unable to concentrate. They worry from one topic to the other with occasional onset of palpitation. This is generalized anxiety disorder. When the anxiety comes in a specific situation or object, that is phobic anxiety disorder. And the type of situation determines the three subtype of phobic anxiety disorder: the specific phobia, the social anxiety disorder or social phobia, and the agoraphobia. The specific phobia is commonly fear of things like animals, rats, height, space, things generally, but you people have different names for it, but we do not call it any of those names. We just call it specific phobia. So if it's fear of insects, they say entomophobia, but it's just specific phobia that we look at it in general terms. Now, but if the fear is those who are afraid, their fear tend to come in any situation that they are under scrutiny. Anywhere you are, like now I'm under scrutiny, a group of people are looking at me, I'm being judged somehow in a small group. For example, presenting in a seminar in your class or performing in a stage or something. If the anxiety always comes in such situation when you're under scrutiny, it's called social anxiety disorder or social phobia. This is particularly important because many people who have social phobia, they tend to abuse substances to mask their phobia. For example, I'm going to perform before the class. That's when I started taking alcohol so that I can mask the anxiety. So before I now know it, I become dependent on alcohol. I smoke a little Igbo to be able to make my performance in the stage. Before I know it, I become dependent on it. So when I see a young person come with substance use problem, I want to find out about social phobia, whether the person was self-medicating himself before he now secondary got hooked up with the drugs. So that's about social phobia. Then agoraphobia is commonly crowd, anywhere the individual think escape is compromised. For example, in an enclosure, if the anxiety comes in these areas, it's called agoraphobia. But for panic disorders, it is the difference between panic and generalized anxiety disorder is about the speed of the anxiety. So in panic, the anxiety comes overwhelming, like it reaches the highest, the person collapses. You think the person is going to die, but in a few seconds, the person is okay. Sometimes you pour the person water or something, but those things doesn't necessarily help. It's just that the anxiety has cleared. So in between attacks, the person is okay. So it is called paroxysmal anxiety, episodic anxiety. Unlike GAD, that generalized anxiety that is always there, this one comes in episodes like convulsion, and then in between it, you're good and all that. Of course, the other types are commoner in children. The separation anxiety and selective mutism are there. So these are features of anxiety, and so anyone you do, many of us may have anxiety. It's normal to life actually. When I'm going to speak to the Senate, if you feel anxious a little, I may go to pee 10 times before the time, but this anxiety is required for me to perform. So once I'm in the Senate hall and I'm talking, I'm good. But it
Get over
becomes
it.
pathological when this anxiety now makes you to seek health as help a little excessively. You are now unable to now you avoid situations like you're supposed to travel by aircraft to London. You cancel it because you are afraid of joining the aircraft and you cannot escape. It's an enclosure. The anxiety will make you to avoid, or you're supposed to go and see your daughter, but because you're going to pass through an elevator, you say you are not traveling. At that point, it's causing you disability because you're not able to do the things you're supposed to do. It has become pathological. Thank you very much.
I used to have this anxiety about rats. I don't know how you mentioned it, took me years back. So I had this experience when I was quite little, and I'm scared of rats. So I can relate to how you're saying someone is having anxiety. Like if you see me and any creeping cockroaches or rats, if you see me, you'll be shocked that this is the person and how she's how she's behaving because of that. But that's due to an experience I had when I was quite little, and I think it's still affecting me even up till now. I also like how you highlighted the use of drugs. So we are seeing a massive surge in drug abuse, alcoholism, chronic sports betting. We're in the World Cup season now, and I know It's said that this World Cup is going to be like the highest. Someone said I hate cockroaches. This World Cup is going to experience like the highest betting season of all time, billions of dollars. Nigerians are not in the World Cup, but I know they are there with their phone. They are betting. And it's becoming a concern. I also heard of someone that, due to presenting, is an entertainer, he started taking some medication and he also got addicted to self-medicating, like you said, and he also got addicted to those medications. So, from your psychiatric point of view, is it just moral failure or men? Because men, they are betting more than women they are taking alcohol and drugs more than women. They are abusing it more than women from the statistics that I've seen. Are the men using this addiction to cover something like a mental distress, or is just a moral failure? I'd like to get that, well, we would like to know.
Dr. Tokwe, you can go on with addressing this. Is it a moral failure to get dependent on drugs? Yeah.
Okay. All right. Thank you. So I'll start answering the question by saying something that Dr. always says. And he says sometimes the first decision to take a psychoactive substance may be yours. So it may be your decision to smoke for the first time or to do any of the street drugs. But in certain populations, continuing to do that might be out of your hands. So dependence, which we may sometimes refer to colloquially as addiction, is defined as a chronic relapsing brain disease. So there's a long road, sometimes a short road to dependence. And there are different ways to view it. Some people view it as a moral failure, but we know that as human beings, we are largely shaped by our environment. And in certain situations, psychoactive substances like alcohol are culturally acceptable. And depending on exposure, a lot of persons will try a substance for the first. Where the problem might begin to come in is when they now continue to try it, and then something called tolerance happens where they need to take a larger amount to get the same effect. And from there, it's a downhill road. They might not be able to terminate use at will. They might not be able to concentrate on other things. But at that point, it is out of the will of the individual. It has now become a psychological problem. And if we are to address the problem, we are going to have to drop our moral. We may have to address it, from a clinical point of view and not from a moral point of view, in order to help persons who are taking substances. A lot of people might make the decision to start, but a lot of people definitely it comes. It's a decision that now they can no longer control.
Thank you very much, Temi. So there have always been this debate about, is it a moral problem? Should people spend their money trying to treat people who chose to smoke or drink and then they now have issues with it? Or is it a medical issue? Now the debate is endless. It just depends on your point of view. But I'll tell you what we know as clinicians. Just like Temi said, when you first use anything, it's usually your choice. It's a voluntary decision to go and smoke or not. So your frontal lobe is obviously in it. You have thought about it. You have made your decision. I think I want to go and drink. That is your decision at that point in time. Now, but if you continue to use it over time, the brain responds in certain ways to pleasure. Why would you go back? Is because the first one gave you some pleasure. Either you forgot your trouble, you slept well, or it made you to be high. So that response is registered in the part of the brain that stores pleasurable events. Now, after some time, the brain begins to crave for it. And at that point, the individual no longer determines when to start, how much to take, and when to stop. At that point where there is loss of control, it means that it is now the brain that is driving your use. It is no longer a voluntary decision. If you choose not to drink, your body will start shaking. You will vomit. You will, so many things will happen to you like you want to die. You have to drink to cure it at that point in time. At that point, you are already ill. You're no longer, it have lost the effort of will. So at this point, it has become a medical issue. So people can say, well, it's a combination of the two because the first choice was you that made it. So it was your moral decision. But at a point where the substance have taken over, when we say you are now dependent, you cannot by effort of will just stop because the withdrawal symptoms will be so dire that you cannot rest until you take the drug again. That's where treatment is required. Not just only at that end, there is a spectrum. There are people who are having a harmful use of it. They are not yet dependent, but their use is now making them to have financial problems, like they are owing many people, that are unable to fulfill their work role, or that have been arrested for being drunk and driving. This is not yet necessarily yet a dependency syndrome. It is called harmful use of drug at that point. But with time, the person may graduate to the point where the drug determines when to start, how much to take, and when to stop. At that point in time, the effort of will is lost. And that's this individual, you cannot just say, I please in Jesus' name come out. No. At that point, it has become a brain pathology that have some specific way, including spirituality, no doubt. Now, but it's no longer like a primary thing, say, oh, go off it in Jesus' name or something, the person goes off. There are some particular way this individual have to be treated. And even with those treatments, the chances of returning back to it after some time is still there because these drugs are centered on pleasure. Whether it is food, drugs, sex, man will always seek that gives him pleasure. Yeah, thank you.
Thank you, Dr. Anu. Thank you. So if we have a family member or a friend and we notice that he's drinking or gambling has crossed the casual one, like you said, maybe harmful use, and it's now dependence, destructive and dependent on the substance or whatever addiction is going, what's the best approach to medical approach to intervene? What are the
Okay, so
steps?
first of all, I'll just list the parameters you will use to know that this has become a problematic use of any substance. Yeah, just for the sake of knowing. And it's not just about substances. There are two
Okay.
behavioral addictions recognized as a disease currently. First is the substance use, and secondly is gambling disorder. So these two, like you just mentioned, are well known as disorders in medical diagnosis. The other ones like internet addiction and the rest of
Yes.
them are yet to be included into manner. So of course, if you have substance or gambling disorder, if you're in US, insurance will cover you. But any other kind of addiction is not yet recognized as a medical disorder. So insurance will not cover it because it's not yet a disease currently. But over time, they expand diseases as the year
Mm,
go by. But currently, substance use
yeah.
and gambling disorder are considered as medical conditions. So how do we now know the threshold? Well, four screening questions that you can commonly use. Four. We call it CAGE. It's like a CAGE questionnaire, CAGE. CAGE. The first is if you ask the individual, have you tried to cut down on the quantity of whatever he's taking? Even if it is gambling, have you tried to reduce the number of hours spent in gambling?
Mm,
The answer is either yes or no, right? So the second one is A. That the C is cutting down. That's cage. Second one is A. The A is anger. You ask the person, do you feel angry if somebody criticizes your habits?
mm,
It's either yes or no. The third is guilty. Do you on your own feel guilty about your behavior?
mm,
And then the third one is eye opener. That is the E. Have you ever gambled or used any drug first thing on waking up in the morning? Any two positive answer, any two yes, tells you that this person may be having a problematic use of whatever, whether it is alcohol, cannabis, cocaine, or even gambling, any two positive answers is an indicative that this is not a normal use. Now, you now want to ask more questions, 6 questions. 6 of them, any 3 of it will tell you that you're already dealing with a dependency syndrome. First is an irresistible urge to use, which is craving. Does this individual have an irresistible urge to gamble? Does he have an irresistible urge to drink? 2, the quantity the person used to take before to get high, has the person have to increase it to get the same effect? For example, I used to take 1 bottle to be high, but now 3 bottles no they do me. That's an evidence that this person is moving, is getting dependent. Then the third one is when you stop, if you don't use it for a few days, if you decide to stop today, do your body respond somehow? Do you feel somehow, And the way they feel, what we call withdrawal signs, is dependent on the drug. But the real question is, if you say you will not take today, do your body respond to it somehow that make you to go to it again? That's the third question. Then, have the person neglected alternative sources of pleasure? Have the person now, this substance is becoming the most important thing in your life. So you think about it on waking up, during your workspace, and all that and all that. That's primacy of use or neglect of alternative pleasure. Have this thing caused you any problem? This problem can be physical, can be in your relationship, it can be at maybe you now put your opinion in the house and they say, leave this man, he's a drunkard. Leave this man, is smoking Igbo. So it means your contribution in your family circle is not even valued again based on the label that you use drug or something. So I've mentioned about 5. I can't remember the 6th one, but at least 3 positive of this in the past 12 months. It's an indication you're already dealing the most extreme, which is dependency syndrome. So what do we do? It is better to reverse, it is better to prevent the onset of use of substances in the first place. As I said last time, the age of initiation is quickly dropping. So you can see 9-year-old, 11, 12 using substances. And this is very bad because the part of the brain that is responsible for judgment is not yet mature before 25 years. So people who start using substances excite a lower part of the brain, making the seat of judgment to be a little redundant. So they are unable to judge their behavior as appropriate. So unlike those who started smoking around 30, one day they can come up and say, nah, this thing no, they give me anything. Now, it just they drain my money. I no go do again. People who started smoking before 25 are less likely to make this level of judgment. Those who started after are able to do it because their frontal lobe, the seat of judgment, has developed, so they can make the judgment. So it is good that we prevent. First of all, good neighborhood, the environment you live, environment that drug is scarce, because the most important factor to use is our variability. Things that are available are most likely to be sourced and used. If you have to travel miles to get something, you may not be interested in it. So good neighborhood, taking extra effort as parents to get to know the warning signs in our child, which is basically, is my child spending a little more money? He used to get a pocket money of 10,000, but now he's demanding 100. That's a red flag. 2, is this person always, when he comes home, he tends to stay alone, not mixing up with the family? You have seen him repeatedly with red eyes. You have noticed that he's declining in his academic performance. You have heard that he no longer attends classes. These are red flags. You don't need to wait. And I recommend for those of us who are parents, you could even institute some periodic urine check of your children about drugs, so that you tell them, I'll be checking you for drug, but it's at my own time. I'll check it at any point I want. So they know that there is no particular time. The father can come up and say, bring your wee-wee. So anything you can do to prevent them from using early in life, until at least they are out and leave your house, at least they would have developed their frontal lobe. They can make decisions they are less likely to be influenced by peers because they can judge things better at that point in time. Do it. So prevention is care. But for those who are already ill, first of all, it depends on your level of motivation. So first, what the doctors do is to assess your level of motivation to change. Some people may be at the pre-contemplative phase. They say, oh, this substance is the best thing that have happened to their life. In fact, in US, they can quote for you where it has been legalized. They can tell you that cannabis is used even in medical treatment. So they idealize, they make it look like it's the best thing in their life. So this person is no longer, is at the pre-contemplative, is not even thinking that there is a problem. So at this point, the doctors or whoever is treating the clinical psychologist, they do what they call motivational interviewing. So they try to help you to understand, to move you from that stage to a stage of thinking, oh, could it be that all my troubles may actually be related to my habit? At this point, this individual will say, oh, there's a possibility that this is bad. At that point, the person is contemplating. And then the person may get to a point of saying, oh, I think this is bad. I want to take a decision. It is at that point that the person is enrolled into a treatment facility. But even before the person gets enrolled, we do not discard you. We keep having the conversation because we know that change doesn't occur in a day, right? So the clinician opens the door. So, okay, even when you have said that this is the gospel for you, can you drop in next time so we still talk about it? So you drop in next time, you say, oh, what's your goal in life? You say, oh, I want to be a doctor. You say, okay, that's interesting. Yeah, so what's your grade in school? He said, no, I've been getting F, 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 F. Have you been attending classes? He said, no. Why? Sometimes I have to stay up to smoke a bit. So you say, okay, oh, so do you think your habit is somehow trying to affect what you want to be in future? And you say, oh, I never thought about it this way. I think he may be. So this is an individual, you're trying to motivate the person to move from a point of thinking there is no problem to a point of thinking there is a problem. And once you get the individual to that point, the individual can now one day say, doctor, I think I want to stop. It's at this point that you now design the treatment program, which are sometimes a combination of mostly psychological treatment plus medications. But if somebody comes to us, we go through like 4 phases, which is if we admit you, if we need to admit, it's not in all cases that you admit. But if somebody uses some drugs that their withdrawal can cause death, like opioids, the benzodiazepine and alcohol, their withdrawal can lead to seizure and can kill. Those ones, we want to keep them on admission. So we will go through the detoxification phase, which is weaning you off the drug. And then we go through the stage of stabilization and maintenance. Then we prepare you for the real world, what we call relapse prevention program. And then we continue to follow you up over time. You know, we don't care, even if you stay 2 years, 1 year without, it's enough for you to graduate in secondary school or university or to get married, a feat you may not have achieved if you have continued to drink. So even if you go back again, we clinicians, we don't get angry. We just want to learn from your circumstances that made you go back, beef you up again, return you back to the society, because we believe that any treatment, any level of abstinence covered is enough to make an individual achieve 1 or 2 milestones, which wouldn't have been possible if the person have remained in the drug of abuse at that point in time. Thank you.
Thank you, Dr. Onu. I saw one of our participants giving a breakdown of cage. It's quite interesting to know. We have a culture of taking questions later. So if you have any questions for Dr. Onu, you can drop them and we'll take them shortly. Dr. Onu has explained to us provision. We usually say this word in worry. Provision store is better than chaos, but in the sense, what it's just trying to say is that prevention is better than cure. So that is the part I'm taking. But he has also made us understand that we don't discard when there's a problem. We also have procedures we can take and we'll get better. Never stop trying. So if you have anyone going through any stage of addiction, the person is not a lost battle. There's hope. Dr. Ono has given us some steps. So Dr. Ono, thank you for the brilliant analysis. In Nigeria, we have this crazy, intense hustle culture. Every day, there's this line, Yakubu, manage! It's going to do you like you want to die, but you will not die. So, doctor, please help us. What do you have to say? A friend of mine told me recently that sleep is for the weak. Yes, no sleep. So, we are not sleeping. Please tell us what's your advice to those men and women alike that are currently burning the candle from both ends? What can you advise us to do?
All right, so I think this question, I'll take it to Temi. She's a specialist in workplace mental health
Tell me,
program.
we need your volume to be steady because we've been
Yeah,
having some wave.
yeah.
We
So
don't want
Temi,
to
please
miss out on
try
anything.
to shout. I know that there's code where you are, but just shout it out. Yeah. All right. So Temi, go on with this. Yeah. Thank you.
My voice tends to echo, so I try to be mindful. Can you hear me clearly?
Perfect.
Okay, yeah. So for us to talk about it, we must be aware of the system that we work in and the peculiarities of the system that we work in. So you have to identify what is prevalent in your place of work. Is it performance based? Some places of work just like your results, and that's good for them. But some people, some places of work prefer something called showmanship, and you may need to learn how to be versatile and do a little bit of both because the government is not going to give you benefits for being unemployed. You have to keep your job. So it's important for you to be able to pick out the good parts of the job, pick out the bad parts of the job, pick out what you need to do to adapt to the work that you are doing. That being said, I'm not saying that if a job is it is
Topic.
yeah, it is toxic that you should stay there forever. Of course, with a backup plan in mind. So, what are some of the things that make you know that you're experiencing burnout in the place of work? There are some things that used to drive you, and then nowadays you realize that you seem not to care so much anymore. So you seem not to respond to something like apathy. Like you just I'm neither here nor there. I don't care about what is going on. Prior to now, when you receive performance appraisal, you're like, okay, I'll do this, I'll change this, I'll correct it. Nowadays you go to work and there's no emotional connection to your work, or you seem to have checked out. That's a sign of burnout. Also, being overly emotional at work is also a sign of burnout. Another sign of burnout is, feeling that this overwhelming sense of helplessness, as if nothing that you do is good enough, is also a sign of burnout. And there are things that can be done. There are the factors that relate to the person and factors that relate to the workplace. So
Mhm.
things like sleep, things like diet, things like healthy habits, those are within the
Your
person's
control.
control. Yeah. So you can work on prioritizing tasks, making lists, trying to, for example, some people have issues with a coworker that always piles on tasks. You can learn communication. So, okay, you gave me two tasks yesterday that are supposed to take a week, and now you're adding another one. Do you want me to let go of those ones while I complete this? A lot of times in Nigeria, I'm so combative. This person doesn't like me. This person did this. You can actually go through. You might be surprised at what will come out of that conversation. These are the things that I'm already doing, and try to show that you are doing something. A lot of us have not learned how to, document properly that we did this and we did that. And then you can be filming somewhere and saying my nobody's
Effort.
recognizing my efforts, but we don't know your organization doesn't know that you are doing those things or that it's taking this amount of effort to do it. So you can present yourself in such a way that it is seen. I know that there are toxic places that there is nothing you do, um, but it's important to look out for those parts that are modifiable. And of course, if for any reason you can connect some of the things we've spoken about today, um, the depression, anxiety, you can connect them to events, your
Your work.
workplace. It is work. There's nothing in my personal life. is work. When I think about going to work on Monday, I don't have any energy. My mood is low. I cannot, I have headaches. I fall sick every other time. Then it's important to take it serious. A lot of people commit suicide and people say, oh, he was fine. He went to work yesterday. Don't know if it's the working place, you know. So it's important that when those things are very present, that can begin to seek professional help. Don't know if Chief has any other.
Yes, so thank you very much. Yeah, so that's it. So for me, many of us here may be administrators, we may be owners of companies. So for those in the providers, that's the organization, because we have roles to play in burnout. So it is good that we have policies. In case you are a CEO here, it's good to you can take you can take your policy to maybe a psychiatrist, a mental health expert, to look at if your policy has things that actually negate well-being, because eventually it will lead to reduced production or productivity of your workers. So companies that are aware actually tend to bring out their policies, their human resource or their various policies to mental health experts to scrutinize. They may pick one or two things that actually will not be very helpful in terms of the future of your workers. Now, but for those of us who are workers, of course, Temi has mentioned so many things. Personally, when things are that flooded for you, part of the things you can do is what we call journaling. Before you go to bed, do not carry any company of into your head. Write out every single activity that you were not able to do. You can set up plans on how to do them. Write it down before going to bed, so you don't begin to debate about work while you lie down on your bed. So it's a process we call journaling, or emptying your brain. So at the end of every day
Mm.
work, if you have so many unfinished tasks, come home, write them down. You could make plans about what to do about it the next day, but just get done with everything before entering that your room to sleep, so you can have a sound rest and not be there debating the ones you didn't finish and the ones you finished, and it will cost you your sleep, and then you become a little more irritable the next day, and the cycle continues. Thank you.
Thank you, Dr. Temitope and Dr. Onu. So the Nigerian mindset, they say journaling is for the white people. It actually works. It does. You should try it. You should try it. So, doctor, what are 3 signs a man should watch out for before he gets a mental breakdown? What are the signs due to work pressure? What are the signs that I am seeing or I'm feeling that this is a sign for me to take a break?
Yeah, the commonest features of burnout syndrome, really, the first is emotional exhaustion. So these feelings of being exhausted, you know, is the core. Then there is the second one we call depersonality, feeling that you're not real. You just have this feeling within you that is this still me or something? And then if you now notice that your productivity is reduced, or you have this sense of reduced accomplishment, you
Mm.
know, these three things, could be an indication that somehow you're no longer coping at your place of work. There are other things like, feelings of tiredness, poor sleep, and all, but it's commonly an emotional exhaustion, a feeling
Mm.
that I am not ready again. And then there is decrease in your accomplishment as a person. The way you used to be productive is gradually fading. Mistakes that are uncommon from you is now becoming almost everyday thing. And then at that point in time, you may not just be coping. Yeah.
Brilliant. So we all need to learn how to pause, take deep breaths, relax. Rest is not luxury. It's actually the best medicine that we can give to our body. I struggle a lot when I don't sleep well. So I know the importance of rest. I know Nigeria hard, but let's just find a way to manage ourselves, especially when it comes to our health, mental health, physical health. Dr. Ona, I'll feel like some of the work pressure that we experience can also manifest as people having palpitation and also high blood pressure, because when the stress hits, I think it affects our brain as well as our heart. I don't know if you can confirm that clinically, but
Yeah,
I think
that's correct. Sometimes when people have anxiety symptoms, I do not I don't normally agree with diagnosis of hypertension at that point, because
okay.
normally your blood pressure is actually in mathematical term, your BP is your cardiac output. That's how much your heart pumps
Hmm.
times the resistance from the blood vessels. Now,
Okay.
anxiety will increase your heartbeat and it will also narrow the vessels. So those two factors will increase the blood pressure transiently. So at that point in time, your blood pressure may be elevated and you may think you have hypertension, but within few hours of gisting and laughing, your blood pressure drops.
Yeah.
So that tells you that it's not necessarily hypertension, it's just the anxiety that shot up the BP at that point in time. So commonly, so if I have a patient with anxiety and they are treating, commonly they would have given them drug for hypertension. I will naturally just watch, take off the medication for hypertension if it was diagnosed at the same time of anxiety, handle the anxiety issues while I watch the blood pressure. If the blood pressure persists beyond the time the anxiety has been settled, then I'll now say, oh, you have to see a cardiologist. But if the blood pressure stops when the anxiety is done and you're okay, no blood pressure issues, I'll just tell you that it's related to your anxiety at that point in time. And it's not necessary you do have hypertension at that point. You may develop it later, but at least not at that point in time. Yeah.
Okay, doctor. Thank you very much for that clarification. All right, this brings us to loneliness. So research shows that severe loneliness is physically as deadly as smoking 15 sticks of cigarettes a day. I'm sure, Dr. Onu, you don't have the regular man walking to your office to say, Doctor, I'm lonely. That's the problem I have. So they are suffering and they are there. The older they get, the less social they become as well. Even as it is now, the beer parlor company that they normally go to get, they don't really go as much, because once you step out, a bottle of alcohol now is even expensive. So some men are also trying to manage their pockets. So I think it's getting worse. Loneliness, they are feeling it. So my question is, what can you tell us about loneliness and how it affects the mind of the average Nigerian man?
Okay, so loneliness is really a problem. Remember that by nature, especially in African society, we are collectivist in our society. We are communalistic in the nature of our community. So inherently, most Africans live in a community. So when there is sense of isolation or loneliness, it
Hmm.
poses much of a problem to the health of the individual, both your physical and mental health. This is not just about males, it's also for females. Remember the emptiness
Okay.
syndrome when your children are leaving home, so they have gone to boarding house or they've got married, but female obviously tend to compensate for this by joining meetings, women meetings,
Oh, one
doing
bed
things in
weekend.
church, yes, visiting their children for mogo and all that. But this is not the case for men. In fact, in your local church, you find out that the thriving societies are those of the females. So when it is Mother's Day, everybody gets to know. But when it is Father's Day, the arrangement is just, in fact, Mother's Day in my church will start 1 month to prepare. But for Father's Day, it's just going to happen maybe that day. All of us will present ourselves and all that. So you can see that these differences in the social milieu of male and female, tends to be problematic to male mental health. In fact, in one of the therapies, form of therapy we call interpersonal therapy, one of the core domains is addressing loneliness, and isolation. It is an important risk factor for development of health issues, not just about mental health. Risk of falls, men that are isolated tend to fall and they could actually die from fall. You've heard about people who died many years or many days undiscovered, men because of loneliness and isolation. So, loneliness is not a positive mental health attribute. It is a negative, it has negative implication to the mental health of not just males, but females. And males have less compensatory mechanisms with regards to addressing their loneliness. So, what can we do? Well, the era of social club, there was a time that men used to do their social club thing, and that's where they hang out, do their meetings, dance, socialize, but our society is turning a little more individualistic now. But we do still know that there are places where people come out to do sports in group. You see elderly men join them. These activities are very important. Activities done in a group, and then having, some people also have some clubs. Their social clubs, and they join it, and those men tend to be a little more active. Now, but loneliness is in itself a problem, and it's something that everybody should be aware of because our network tend to reduce with time. Your friends die, your age mates are late, so you are just somehow, living in a world, but you have little or no people of common interest. So taking a group exercise, joining a group that tries to motivate you, is a very useful thing to try as part of the ways to beef up your support system, as men. Thank you.
Thank you very much, Doctor. Thank you. Thank you so much. If you have any questions, we'll be taking them shortly. Please drop them on the chat. Thank you so much. So, Doctor, what are the behaviors we should watch for chronic loneliness? What can we see?
Well, commonly, it comes with some level of isolation and avoidance, So, this individual, as you said, it's not like it's a disease itself. Loneliness is
Mm,
not a disease, yeah. So, the person there are some personality predisposition anyway to people who just want, some people are isolated in that manner. So, they are loners. They tend to function like in a desert where there is nobody or something. It's basically social avoidance. So these are not necessarily a disease condition, no. So, but these individuals are isolated, may have difficulties in their emotions, their mood may not be as optimal as it could be. And then they are socially awkward too, unable to connect socially. Yeah, so it could be due to their personality predisposition or just about life experiences. Yeah, so but loneliness is not in itself a disease. It's just a situation that can arise based on our personality or our social conditions.
okay, I know that suicide in young people, they are higher because we have more young people in the population. But I also know that there's a link between being lonely and also a high rate of suicidal activity at that old age. So that's why I'm asking that question.
That's correct, but not necessarily because of
Okay.
loneliness. But just know that people who have limited support system, the issue is not, it's about the support
Mm,
system available to this individual. See, many people that have thoughts of suicide want to talk to somebody. So, contrary to what we
mm,
think, people who have thoughts of suicide really want to confide in somebody. Sometimes they go online threatening to die, just looking for who could call them. And then the society fails them by not, people will just dismiss them as trying to catch attention. So
mm,
it's the same part. So men who are lonely, maybe at a certain age, are also prone to suicide, not because they just don't have people to talk to. Because when they talk to you, people may provide them hope, you know, but they want to talk to somebody, but they have nobody to talk to. So eventually, of course, it will evolve to the point of hurting themselves, and it may even take months or days before they are discovered. And that's also the danger of the social media. You know, social media is increasingly making people isolated. Young men and women are increasingly being isolated by overutilization of social media. They think they're in connection with the world, but there is no physical connection. There is just a virtual meeting. So people are increasingly becoming isolated, and suicide obviously will increase. UK is currently discussing about reducing the use of social media or smartphone by
For
those
young
below
people.
16. Yes, below
Yeah.
16 years. These are people who discovered it, but they are talking about it. This is not arbitrary, they are guided by science.
Hmm.
So people are now having so many friends they will never meet in their life because they stay in their room and connect to virtually everybody. That's the highest stake of isolation. And it will not be very far. We see the boom of suicide related to loneliness coming from, social media, over utilization of social media that have limited physical contact with other individuals. Thank you.
Wow, that is profound. I've always said it that we are social beings. Even the social media most of us were using, we prefer to, it was created, for example, Facebook, for people that are maybe far away, friends and families to connect. But that's not it anymore. People just want to connect with strangers and even abandon the people that they can actually meet physically and communicate with, like their immediate families. Teenagers keeping themselves indoors, just chatting with people that, like you said, they will never meet. And you see them, they are extremely moody. They are moody. I don't know, but I'm happy that steps have been taken to cut it down. I think countries like Australia, they already have it in motion. No social media for children or teenagers, people less than 16. So I hope as a country we would also, we are quick at learning things, but we tend to not look at the negative impact. Um, I think I am done with my questions here. So let's see. Do we have questions on the chat? Okay.
So somebody is raising his
Someone,
hand. Mhm.
okay, yeah. Do you want to speak? Okay,
Yes, 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 yes.
all right. You can go on if you ask your
Okay.
question.
I think anybody that is on this call should take this that they have been very blessed to be here to learn so much. So I have four questions and I'll try and see if I made them real quick, because I'm particularly pleased with all that is happening today and the learnings. Now, one is this. A student just called me, and that was about 2 hours ago, that her parents, her mother and father have disowned her. And I said, why? She said, because they caught her with drugs. And this session was about to start. So it's also interesting. Like, this session was about to start. So I just told her, okay, just wait, let me finish. I want to, or meet the clinician. I'm a professor of social work actually. But okay, meet the clinician or call them up, let them be talking to you. I want to enter a meeting real quick. And then I will come out and respond. And then I got into this meeting. My question will now be, um, I mean, I've not yet found out the circumstances under the issue, but she said they've driven. In fact, her father said he will never see her again in his life, and her mother. That is just about 2 hours ago. So we have this case, this client already on ground. That is number one, and how best to address it is another matter. Trying to work on the protocol. Then, secondly, there's another stuff. We see the issue around depression. It's not depression. This one is like, it's a combination of what you have said, like panic attack. A person will sit down and there's panic attack, and one thing that happens is you see the staff crying, as in crying, and getting up, like the next thing you see the person in the clinic, in the not clinic, except hospital. Like, what is the matter? What is the matter? So that is one of the, so a protocol
Dr.
to address
Anu,
such.
please, did you get question?
Yeah, yes, I can hear her very well. So it's 4 questions. She's on the second one. So go on. There are remaining 2 more.
Yeah, so
Yeah.
the third one,
Okay.
the third one is the fact that you start to see and dream, and well, I would like call it dreams, the imagination that, okay, Dr. Onu is going to jump over a bridge. Okay, Sentinel is going to enter into, jump over the mountain. Oh, somebody is going to jump on her head. Those kind of things. I don't know if it's part of, will I call it part of the panic attack, and these are the claims we have, like, right now to deal with. Then this issue about death. As an individual, I hate dirt. As in, naturally, I hate death. But I did not know I did not know there was a panic side, to it, in terms of, if I see dirt anywhere, or if I see what they call cockroaches. If I ever see a cockroach in your house, I will never visit you for life. As in, I will never come to your house again. I don't know if I'm trying to am I making sense? I mean, I'm in regards to what we are talking about. If I see
Yeah,
a
yeah.
creepy, no, why you laughing? Like, if I see a
No, no.
creeping object or a
Yeah.
cockroach near your restaurant, I will never go there again. So I don't know, are these all part of the best way to address those things, and all that. And I just felt, let me just ask this ones first, for the meantime. And then if there's room for one more or second, I can ask. Thank you.
All right, thank you very much. So, just to say a few things before Johnson's question. So, first of all, yeah, we'll get to know the circumstance of the student. The point is that, as Ogene talked about the moral things, many people understand substance use not as a medical problem. So many people think it's a moral failure, and when you feel it's a moral failure, you tend to take this reaction like these parents, So they don't. These parents will think this person had failed morally, and that's why he's unable. He's using substances, but of course, when you get to understand the whole situation, you may have to move beyond the person to also talking with the family, so that they know that the exact thing they are trying to avoid, they want this person to be a reasonable individual. Throwing the person away into the world will not happen any of that. So I guess when you take more history, get to know the social situation of the family, you may begin to formulate an appropriate action on how to help. But if you need other kind of advice, when you get to know the whole story, you could also maybe get to hear from myself or Temi on how you can proceed. With regards to the staff, of course, the point is that most people with anxiety disorder may never see a mental health expert. They may be going to see the respiratory physicians, the cardiologists, and that's why hospitals that are very sensitive, like LUT, they have their mental health clinic with that of cardiology in the same place. So that once the cardiologist takes a look at you and thinks that this one is a mental, they just say, go to the other room. You don't know who is in the other room, because you say, go to the mental health clinic, they will not go. They will say, I'm not mad. But they just say, go to the other clinic. So they just move to the other clinic because they are quite close. So it is good to understand that many people may not think it is a mental health issue. But of course, we cannot be discussing treatment over the social media or in this platform. But it's just for the person to know that if you can help the person understand, where I think this thing that is happening to you, need to see a mental health expert. I'm not talking about, let him get to see a doctor who says this is what it is, and then helps the individual either to link you up to a clinical psychologist if you require some level of therapy, or go on to deliver the therapy if he's in the position to do that. And if you require medication, he also helps you in that regard. Then, with regards to you and cockroach, well, yeah, so the point is, do you meet the criteria for all those? The presence of cockroach, does it cause you some autonomic symptoms? Do you have the other things? And can you miss your child's baptism because you saw a cockroach in the church? If these things are true, it means that this fear is already causing you restrictions in your functioning. For example, it had made you not to visit your friends and all that. It's no longer that very normal because it's now restricting your ability to do certain things you would have loved to do. At that point, you may also require some level of help. Psychological help. Basically, phobia is commonly treated by exposure and relaxation. They just help you to construct the hierarchy of fear from dead cockroach to a live cockroach to a cockroach drawn on a paper. And the therapist can help you walk through it because commonly what makes you react the way you react is that you think that the cockroach is more dangerous than, as in the danger you ascribe to the cockroach is more than what it is. And then you now begin to avoid it. Avoidance will perpetuate the anxiety. If I don't get to know this, when we are growing up, we're told that women that have birds are wicked, right? So somehow, if you don't get to come in contact with a woman with birds, you will be classifying the person as wicked from afar. Until one day you step on the person and he just say, "Oh, my son, I'm sorry about it." You say, "Oh, so this woman is not as wicked as I thought." So avoidance perpetuates the anxiety that we have about things. So avoidance does not help. And that's why in therapy sections, they try to desensitize you by trying to construct the hierarchy of fear, expose you through the objects in the least feared to the most feared, and teach you how to relax until you go through them. That is when it is problematic. But we do have our own fears of rats and all that, but may not constitute any problem per se. But if this fear can make you not to go and save your daughter that is under fire in the distance because you think you will see rats, it's a problematic fear, and we should not just let it stay that way. All right. Thank you very much for the question. Yeah. Mhm.
Yeah. Thank you, Dr. So
There's
the next
Johnson.
next person, yeah, you can ask question.
Johnson, please go on with your question.
Professor, thank you very much for. I said if I don't do this, that will be sin on my part not to greet you because I recall that in our last section I requested that I would like to hear your voice again. And
Oh, thank you very much.
yes. So your team, you did excellent, I must confess. Now, few days ago I was in a room trying to deliver a lecture with some professionals. And my son sent me some quick chats and videos and some photographs of a student of theirs in the hostel, two brothers, one stabbing the other one to death almost immediately. What do you think may be a cause, or how do we handle such children within our society? Because currently I manage students and I know that at times some students become aggressive, even to you, the teacher or the lecturer. Then secondly, please, yeah, because I believe that those of us that are here, I am learning every day. As I was even teaching last week, I told the students that I'm here to learn with you. Even when I know some of you even have PhD, you are on your postdoc. I want to learn from you as well, as far as I'm delivering this section for you. When you use the word journey, some of those words are too big. The grammars are big for us, some of us here, and some people that may be on my own side in this webinar here. So please break those words down when you use them and the imperative meaning and what the spelling looks like even. Thank you.
All right. Thank you very much, sir. Okay. So first of all, well, mental health is not necessarily studying on deviance. There are several deviance behavior, that not necessarily in the context of a mental disorder per se. I just want to clarify that. So some people, you remember before now, if you talk about men having sex with men, it's an abomination. But with time, the society have come to accept that these people are not initially, in fact, in the classification of diseases, they were classified as having a mental health issue. Even men desiring to be females or female desiring to be male, we used to call them people that have gender identity disorder. But now, because of their influence in the society, they say that we are not having a disorder. Our brain just doesn't want to recognize our gender or our sex assigned to us by the society. So carefully, those who draft the classification of diseases now say that they have gender dysphoria. In other words, their gender is causing them distress. That doesn't mean they are sick. So just to tell you how society has evolved over time. So deviancy does not necessarily translate to a mental health issue, but there are some deviant behavior that may also be in the context of mental health. We do not know exactly the situation. We don't know whether this man is intoxicated and is hurting the brother. We don't know whether it is some form of cultic activity. You just don't know exactly what it is. Now, but what I do know is that aggression may be provoked or unprovoked, and we do not know all the circumstances. But what we are sure we could do is that there are ways to de-escalate situation if we are involved. So there are ways to de-escalate a situation that may turn violent. And it's a whole series of training on de-escalation. And of course, if you have issues with anger, there are also ways to do anger management. Now, but we cannot necessarily say what the situation is until we get to have a background story. But just to say that deviation from norm does not always necessarily mean that there is a level of mental health issue involved. Some people are deviant and they have no mental health issue at all. And that's why the law always look at those subset of people who have some level of mental disorder that distorts their ability to think. But many individuals do have this ability, but chose the path they want to choose, or they have chosen. For the second question, we meant journaling, like journal. So I try to explain it. It's just for you to empty. It's just like emptying your brain. For example, I have so many things to do. So sometimes if you don't do that, you may go to your bed beginning to calculate all the things you didn't do, and that will deprive you of your sleep. So part of the ways to end your activities for the day is when you come back before you go to bed, you sit down and empty your brain, write down every activity, the ones done, the ones unaccomplished, right? And leave it there on the desk and go to your bed so that you don't begin this debate while you're lying down of whether I'm supposed to go and buy akara and I'm supposed to do this tomorrow, do that, do that, do that. Those debates may cost you your sleep. So journaling just means trying to write down the things you're unable to accomplish for the day, leave it out there. It's a way of emptying yourself. It's a form of relaxation. So you empty yourself and then go to bed without having to have those debates. So those are the answers I can provide to this. Thank you.
Thank you, Dr. Ona. I have a question here. It said, if someone is exhibiting any of these signs of workout burnout, are there steps that can be taken to get professional help?
Yeah, first of all, you may not necessarily need so much of professional help at this point. So basic things you can do in your routine can help you. Things as basic as exercise. I mentioned it last time, 30 minutes of brisk walking could be very, very crucial at this point. If you have a specific individual that is a source of stress to you, having a reappraisal of your encounter with the person, not having a high expectation. At least, for example, if you're expecting to be commended, this person is not going to commend you somehow. You may actually have reappraise yourself that I'm not going to get any commendation. So if they don't do it, it doesn't hurt you again. But if they do it, you say, oh, well, this is a good one anyway, and all that. So exercise, trying to take a vacation, just can take some break from work. and then but not take it to go to your house to do nothing. Use it to reconnect with family, with friends, just strengthen your social support network during this period. So but if you have tried this little ones and it's not helping, and then you think you need a professional help at that point in time, just can get to any mental health expert around you. They evaluate you a little further to know whether it's just only work related stress or are there other things now coming on in addition to that. If there are none, most likely nobody is going to medicate you. But unless you have strong difficulties with sleep, and then they could use what they call sleep hygiene, which is basically trying to recondition you to sleep. For example, they don't want to go into your bed and watching television or pressing your phone. They want you to just go to your bed only to sleep and maybe for sexual related activities. In other words, they want you to condition your brain to to associate lying down on the bed to sleep. Then they want your environment where you sleep to be neat, your beddings to be neat. You don't need to stay where you'll be scratching your body or be unduly hot. The lightning, it should not be too bright, when you're back to your bed. And even the screen you use towards evening, the screen for your phone, your laptop should be such a way that you set it to dim, because light changes the melatonin system. Melatonin is the hormone that is required to help you to sleep. So in darkness, they tend to peak in release, but with light, it may inhibit its release. So if you keep exposing yourself to bright light, even towards evening, the chances that you may not sleep well is higher. Then things like avoiding caffeine containing drinking, including Coca-Cola, it contains some level of caffeine towards that time. Trying to eat early, drink your water much, much earlier so that when you initiate sleep, you don't need to wake up to wee wee again at the middle of the night because initiating it. These are basic sleep hygiene that in many instances may just help you to sleep without having to resort to medications. But of course, when the need arises, sometimes the doctors may also choose to medicate you as the case may be. Right. Thank you. Tell me, I don't know if you have anything you do for your staff when they have issues with burnout. Yeah. I don't know if she's still here. Okay. I don't think I can see Tokwe again. All right. So that's my comment
Okay,
about that.
if I may add something. So we spoke about social media addiction earlier on. Another concern is doom scrolling when you're supposed to be preparing yourself to sleep. Like the sleep hygiene Dr. Ono mentioned, we tend to want to catch up on whatever we've missed while we were working. So rather than us shutting down for the day, we also want to pick up our phones. The more we stay there, the more we lose our sleeping time and relaxation time. So we can also check on that. There are lots of advice to actually keep your phones away from the room where you sleep. So we can add that to our sleep hygiene. Okay, there's a question here. The person has been struggling with anxiety, though not diagnosed. The thought of traveling or flying or any form of fast-moving vehicles can send me to a serious panic mode. Now it's
Yeah.
getting to the point that even going out is a struggle. The
Yeah.
situation of
So
things in Nigeria is not helping matters. I think insecurity the person is talking about.
yeah.
I don't just fear for myself, but my husband and children. This fear just comes. How do I manage it?
Yeah. So that's in the range of what it could be. So it's this fear, it starts somewhere and begins to get generalized. Yeah, all of us do know that there is danger out there. We know we could travel, go to work and be knocked down by a car. We know we could be kidnapped, but it doesn't stop us from going out. Normal people know this danger. It exists in everybody's life, right? But it does not stop them from going for the activity. In fact, it's not the forefront, it's not something that is in the forerunner. They don't wake up with it. So when you begin to have some unrealistic fear, beyond the danger available to you. For example, everybody in the neighborhood goes out, but you have this fear, this level of anxiety that comes in about this whole activities. And now it's even making you not to want to go out. In fact, there is a syndrome we call housewife housebound syndrome. Housewife housebound is that people with anxiety may remain housebound, especially women, because anxiety is actually common in women than men. The only anxiety disorder that have equal prevalence in male and female is social anxiety disorder. So these women may have to ask their neighbor to buy akara for them from market because they don't just want to go out, because they feel that the danger out there is more than the proportion of what it is. And they have fears of real physical symptoms of anxiety during this period. So what I can say is that therapeutic things will not come from this, but it gives you a guidance that there is a problem you have. And the one I can share is that anybody with anxiety, I normally teach them a few things. First is you must have to brisk walk. I keep mentioning it. Brisk walk exercise that lasts not less than 30 minutes, done at least 3 times in a week. It relaxes you and elevates your mood. Two, you must return to your activities of daily living, because if you used to go to church, you go. Not because you feel okay, but that's part of the ways of feeling okay. If you remain housebound, the anxiety does not necessarily disappear. And you will not have to encounter, you will not have the opportunity of encountering the situation you have dreaded to just see that it is as normal as it is, because you have done this over the years, but suddenly at this point you're not able to do them. That tells you that there is a change in yourself. So you have to return to your activities of daily living, church, fellowship, mosque, whatever you used to do, business, every single thing you used to do, because it reduces the time you spend on yourself. Once you are at home, your fears grow a little bigger because it's uninterrogated. But when you get the activities, you focus on other people's problem and then forget your own for once. So that's why returning back to activities of daily living is very crucial. So these are non-medication ways of helping yourself. Of course, there are medication because you have lost your ability to control your nerves. So there are ways to use medication, but it's not something we talk about in this kind of forum. But at least I can share these other non-medication ways you can try, and you may find out in some people it may just be enough to restore them back to their good health. It's just in extreme cases that people may have to move to drugs in addition. So thank you for the question.
Thank you, Doctor. Mo, I want you to ask your questions yourself,
Yeah, so
but
I can
just give me a
understand it.
moment.
Yeah.
Yes. So Doctor mentioned bricks walking, and I am a testifier of that. Whenever I feel a certain kind of way, either too exhausted to sleep or too tired to do anything, I just take a walk, especially when it's not extremely sunny, or you might be lacking vitamin D, just go outside. It's not that bad. Taking a walk actually relieves us of lots of tension. So I've experienced that, and it's very beautiful. I know the security concerns are there. We all have it, but we can't just sit indoor. For example, if you're a man and in quotes, you are your provider, you cannot sit in the house because you are scared of being kidnapped. God will protect us all, but the advice of taking a walk and trying to socialize will also help you get out of that anxiety and panic you're having. So, Mo, if you can unmute, can you just ask your questions? We're trying to round up. Let's make it snappy. Thank you very much.
Okay, 2 minutes. I just said, for example, I have this issue about certification. Are they going to give certificates for this kind of things? And then the way you listed the problems, are there generalized solutions as well that we can note? that we can note as possible solution. Like this brisk walk both of you have mentioned, perfect. Is something I obviously have seen that works for many. So it's something that can come in as a list of solutions. So if we have more like those everyday solutions, it will actually help, restore people. Last but not the least, as a personal experience, I came into Nigeria at a time when the place was so hot. If people still remember that period when it was so hot in Nigeria, and I'm like, I drink water. The water is so warm, even if they just bring it out from the whatever places. And I'm like, geez, so I take chilled. And if I'm not drinking water and it's not chilled, as in chilled, like snow chilled, I will not be able to drink it. I mean, while I do a lot of stuff, but what I think is, should I stop the water? You know what I mean? Like, should I make an attempt to take not Nigerian, that's normal water? Is that a solution? I mean, I'm just feeling, let me bring it to the table. I don't know who else
So
may have this
It's
kind of
fine.
funny.
It's fine.
well, first of all, water is not addictive. So take your water the way you want it to be. Of course, warm water is sometimes preferable in terms of health generally, like not like too cold or something, or but you choose whatever is you really want to drink if it is. But water is not addictive per se in terms of behavior. I agree with you that not everything is medication. Some mild mental health problems may be resolved by psychosocial means. Basically, education, getting to know even what it is, that is not a spiritual attack, may calm the individual. Psych education is the first. Things like reducing stress and promoting social support, and then returning the person to activities of daily living. These three items may, in many occasions, help people with mild, anxiety and depression. Is where you start having moderate to severe kind of disorders that medications may have to come in. And majority of people are actually having mild to moderate. So in other words, they may respond to this psychosocial means, of trying to help the individual. But when the medication is needed, the doctor will always tell you the reasons and how to take it at that point in time. So thank you very much. I think I am getting tired
Yeah,
myself.
yeah. Okay.
Yeah. All right.
You need to rest. We all need to rest. Thank you very
Yeah.
much, doctor. Thank you so much. Another thing is he's mentioning without the use of medications, which I'm also a very big advocate on. The use of rest is very important, even diet as well. We had a dietitian come speak to us. What we put in our body can also affect our mind. So in closing, I would like to thank Dr. Onu and his team for making out time to educate us, and we are super grateful. We have a lot happening in our country, but in all that we do, we should try to prioritize our health, both mental and physical health. I know we made this session especially for men, but I also know that women are getting educated. Remember, help can be being a safe space for someone to share their problems with. It doesn't have to be money. And to every Nigerian man listening, we know that the pressure is much, but please don't carry it alone. You can speak up, reach out. Let's try to protect our mind. I really hope that we'll do better going forward, and I'll see you all at the healthier side of tomorrow. Thank you for joining. Thank you, Dr. Onu, for always turning up for us. Thank you to everyone in this life. God bless you and have a lovely night's rest.